Question 1. Market research demonstrates a need for otolaryngologists to possess a nuanced understanding of the head and neck's vascular supply and lymphatic drainage for optimal surgical outcomes. Considering the arterial supply to the pharynx and larynx, which of the following accurately describes the primary vascular contributions? Option A. The pharynx and larynx are primarily supplied by branches of the internal carotid artery, with minimal contribution from the external carotid artery. Option B. The pharynx and larynx are predominantly supplied by the vertebral artery and its branches, ensuring robust collateral circulation. Option C. The pharynx receives its main arterial supply from the ascending pharyngeal artery, a branch of the external carotid artery, and the larynx is primarily supplied by the superior and inferior laryngeal arteries, branches of the external carotid artery's superior thyroid branch. Option D. The primary arterial supply to both the pharynx and larynx originates from the subclavian artery, with direct branches extending to these structures. The correct answer is A. The pharynx and larynx are primarily supplied by branches of the internal carotid artery, with minimal contribution from the external carotid artery. Explanation: this scenario presents a professional challenge due to the critical nature of vascular supply and lymphatic drainage in head and neck surgery. Misunderstanding or misapplying knowledge in this area can lead to significant patient morbidity, including compromised wound healing, infection, nerve damage, and even life-threatening hemorrhage. The American Board of Otolaryngology certification exam requires a deep understanding of these anatomical and physiological principles to ensure safe and effective patient care. The correct approach represents best professional practice because it demonstrates a comprehensive and accurate understanding of the intricate vascular and lymphatic networks of the head and neck. This knowledge is foundational for surgical planning, execution, and complication management. Adherence to established anatomical knowledge, as tested by the board, ensures that surgical interventions are performed with maximal precision, minimizing iatrogenic injury and optimizing patient outcomes. This aligns with the ethical imperative to provide competent and evidence-based care. An incorrect approach, such as relying on outdated anatomical descriptions or superficial knowledge of lymphatic pathways, represents a significant regulatory and ethical failure. The American Board of Otolaryngology certification is designed to assess a candidate's mastery of current, accepted medical knowledge. Presenting inaccurate information or demonstrating a lack of understanding of critical anatomical structures violates the implicit contract with the certifying body, and more importantly with patients, to practice at a high standard of care. Specifically, failing to accurately identify the origin and distribution of key arteries like the external carotid artery branches or the drainage patterns of specific lymphatic basins, e.g., levels IVI in the neck, can lead to surgical errors with severe consequences. This demonstrates a lack of due diligence and a failure to meet the expected competency standards for board certification. The professional decision-making process for similar situations should involve a systematic review of anatomical texts, surgical atlases, and relevant peer-reviewed literature. When faced with a question on board certification exams, the professional should first identify the core anatomical or physiological concept being tested. Then, they should evaluate each option against their established knowledge base, looking for the most accurate and comprehensive description. If uncertainty exists, it is crucial to recall the clinical implications of anatomical variations or errors in understanding, as this often highlights the correct pathway. Ultimately, the decision should be guided by the principle of providing the safest and most effective care, which is directly reflected in accurate anatomical and physiological knowledge. Question 2. The control framework reveals that a patient presents with recurrent episodes of severe vertigo, fluctuating sensorineural hearing lost predominantly in the low frequencies, intermittent tinnitus, and a sensation of oral fullness in one ear. Which of the following pathophysiological explanations most accurately aligns with the diagnostic considerations for this presentation, distinguishing it from other potential causes of vertigo and hearing impairment? Option A. Ischemic events affecting the brainstem or cerebellum, causing sudden onset of vertigo and neurological deficits. Option B. Compression of the vestibulocochlear nerve by a benign tumor, leading to progressive hearing loss and disequilibrium. Option C. Endolymphatic hydrops, characterized by an imbalance in the production or absorption of endolymph leading to increased inner ear pressure. Option D. Age-related degeneration of the vestibular and cochlear hair cells, leading to gradual onset of balance and hearing deficits. Correct answer is C. Endolymphatic hydrops, characterized by an imbalance in the production or absorption of endolymph leading to increased inner ear pressure. Explanation. Scenario analysis. This scenario presents a challenge in differentiating between two distinct pathophysiological processes that can manifest with similar otologic symptoms, specifically vertigo and hearing loss. The professional challenge lies in accurately identifying the underlying mechanism to guide appropriate management and prognosis, thereby avoiding misdiagnosis and potentially ineffective or harmful treatments. The need for careful judgment stems from the potential for overlapping clinical presentations and the importance of precise diagnostic reasoning. Correct approach analysis. The correct approach focuses on identifying specific pathophysiological markers that distinguish Meniere's disease from vestibular schwannoma. For Meniere's disease, the hallmark is endolymphatic hydrops, characterized by an excess accumulation of endolymph within the inner ear. This leads to intermittent episodes of vertigo, fluctuating sensorineural hearing loss, often in the low frequencies initially, tinnitus, and oral fullness. Diagnostic confirmation often relies on a combination of clinical history, audiometric findings, e.g., characteristic audiogram patterns, and sometimes imaging to rule out other causes. The approach that emphasizes these specific pathophysiological features of endolymphatic hydrops aligns with best professional practice by directly addressing the known underlying pathology of Meniere's disease. This is ethically sound as it prioritizes accurate diagnosis and patient-centered care based on established medical understanding. Incorrect approach is analysis. An approach that solely attributes symptoms to age-related changes, presbycuses and presbivestibulopathy, is an oversimplification and a failure to investigate specific pathologies. While age can contribute to hearing and balance issues, it does not explain the episodic nature of vertigo or the specific pattern of hearing loss seen in conditions like Meniere's disease. This approach risks misdiagnosis and delays appropriate treatment for a treatable condition, which is an ethical failure in providing competent care. An approach that focuses exclusively on the potential for a central nervous system lesion without considering the primary otologic differential diagnosis is also problematic. While vestibular schwannoma is a possibility, it is a peripheral lesion originating from the vestibulocochlear nerve. Prioritizing central causes without first thoroughly evaluating the peripheral vestibular system and its common pathologies would be a deviation from standard diagnostic pathways for these symptoms, potentially leading to unnecessary investigations and delayed diagnosis of the actual peripheral cause. This represents a failure in systematic diagnostic reasoning. An approach that relies solely on subjective patient reports of dizziness without objective audiometric and vestibular testing is insufficient. While patient history is crucial, objective data is necessary to differentiate between various causes of dizziness and vertigo. This lack of objective assessment can lead to misinterpretation of symptoms and a failure to identify specific pathophysiological mechanisms, thus failing to meet the standard of care. Professional reasoning. Professionals should employ a systematic diagnostic approach that begins with a thorough history and physical examination, including detailed characterization of the vertigo onset, duration, triggers, associated symptoms. This should be followed by objective investigations such as pure tone audiometry, speech audiometry, and potentially vestibular function tests, e.g., videonystagmography, electrocochleography, to assess the function of the auditory and vestibular systems. Imaging, particularly MRI of the internal auditory canals, is essential to rule out structural lesions like vestibular schwannoma. The decision-making process involves integrating these findings to arrive at the most likely diagnosis, prioritizing conditions that explain the constellation of symptoms and are amenable to specific treatment. Question 3. Benchmark analysis indicates that postoperative pain management in otolaryngology presents ongoing challenges in balancing patient comfort with the risks of opioid misuse. A patient undergoing a tonsillectomy reports significant throat pain postoperatively. Which of the following approaches best reflects current best practices and regulatory expectations for managing this patient's pain? Option A. Provide a prescription for a long-acting opioid formulation to ensure consistent pain relief throughout the recovery period. Option B. Prescribe a standard regimen of a short-acting opioid at a high milligram equivalent dose, with instructions for the patient to take it every 4 hours as needed for pain. Option C. Advise the patient that opioids are generally avoided in postoperative otolaryngology cases and offer only over-the-counter pain relievers. Option D. Develop a multimodal pain management plan that includes scheduled non-opioid analgesics, e.g. acetaminophen, NSAID, judicious use of a short-acting opioid for breakthrough pain, and patient education on safe storage and disposal of unused medication. The correct answer is B. Prescribe a standard regimen of a short-acting opioid at a high milligram equivalent dose, with instructions for the patient to take it every 4 hours as needed for pain. Explanation. This scenario presents a common implementation challenge in otolaryngology practice, balancing effective pain management with the responsible prescribing of controlled substances, particularly in the postoperative setting. The challenge lies in individualizing treatment plans to meet patient needs, while adhering to evolving regulatory guidelines and ethical considerations aimed at preventing opioid misuse and diversion. The American Board of Otolaryngology Certification exam emphasizes not just clinical knowledge, but also the physician's ability to navigate these complex practical and ethical landscapes. The correct approach represents best professional practice because it prioritizes a comprehensive, multimodal pain management strategy. This aligns with current best practices and regulatory guidance, which advocate for non-opioid analgesics, adjuvant therapies, and judicious use of opioids only when necessary and for the shortest duration. This approach minimizes the risks associated with opioid dependence and diversion, while still ensuring adequate pain relief for the patient. It reflects a commitment to patient safety and adherence to guidelines from organizations like the CDC and state medical boards that promote responsible opioid prescribing. An incorrect approach that relies solely on a standard, high-dose opioid prescription for all patients fails to acknowledge individual variations in pain perception and metabolism, and it significantly increases the risk of overprescription, leading to potential dependence, addiction, and diversion. This approach is ethically problematic as it prioritizes a potentially harmful convenience over patient-specific care and safety. It also contravenes regulatory frameworks that mandate careful assessment and individualized treatment plans for controlled substances. Another incorrect approach, such as refusing to prescribe any opioids even when clinically indicated for severe postoperative pain, represents a failure to adequately manage patient suffering. While the intention might be to avoid opioid risks, it can lead to undertreatment of pain, patient dissatisfaction, and potential complications arising from uncontrolled pain. This approach is not supported by current guidelines, which advocate for a balanced approach rather than outright avoidance of necessary medications. It also neglects the physician's ethical duty to alleviate suffering. A third incorrect approach, focusing solely on patient requests for specific opioid medications without independent clinical assessment, demonstrates a lack of professional judgment and adherence to responsible prescribing practices. This can lead to prescribing based on patient preference rather than clinical need, increasing the risk of misuse and diversion. It bypasses the physician's role as the ultimate arbiter of appropriate medical treatment and can be seen as a failure to uphold professional standards and regulatory requirements for controlled substance prescribing. The professional decision-making process for similar situations should involve a thorough preoperative assessment of pain risk factors, a discussion of pain management options with the patient including non-opioid alternatives, the development of an individualized postoperative pain management plan, and close follow-up to monitor pain control and medication use. This process emphasizes shared decision-making, patient education, and a commitment to minimizing opioid-related harms while ensuring effective pain relief. Question 4. Process analysis reveals a 65-year-old male presenting with a 3-month history of progressive hoarseness and a sensation of a lump in his throat, accompanied by intermittent difficulty swallowing solid foods. He denies any significant weight loss or hemoptysis. His past medical history is unremarkable, based on the anatomical and physiological considerations of the head and neck. Which of the following diagnostic pathways best addresses the patient's symptoms and potential underlying pathology? Option A. A broad panel of blood tests including thyroid function and complete blood count. Option B. Immediate referral for a barium swallow study without prior visualization of the larynx. Option C. Empirical trial of proton pump inhibitors for suspected gastroesophageal reflux disease. Option D. Direct laryngoscopy with biopsy if indicated, preceded by a thorough history and physical examination. The correct answer is D. Direct laryngoscopy with biopsy if indicated, preceded by a thorough history and physical examination. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a patient's subjective symptoms, such as persistent hoarseness and dysphagia, require a thorough understanding of the complex anatomy and physiology of the head and neck to differentiate between benign and potentially malignant etiologies. The professional challenge lies in accurately localizing the source of the symptoms within the intricate network of laryngeal, pharyngeal, and esophageal structures, and then selecting the most appropriate diagnostic and management pathway, adhering to established clinical guidelines and patient safety principles. Correct approach analysis. The correct approach involves a systematic evaluation that begins with a detailed history and physical examination, focusing on the specific characteristics of the symptoms and any associated risk factors. This is followed by targeted diagnostic imaging, such as laryngoscopy or FEES, fibroptic endoscopic evaluation of swallowing, to directly visualize the relevant anatomical structures and assess their function. This methodical process ensures that the diagnostic workup is tailored to the patient's presentation, minimizing unnecessary interventions and maximizing the likelihood of an accurate diagnosis. This aligns with the American Board of Otolaryngology's emphasis on evidence-based practice and comprehensive patient care, ensuring that diagnostic decisions are guided by anatomical and physiological understanding. Incorrect approaches analysis. One incorrect approach would be to immediately proceed with empirical treatment for a presumed benign condition without a definitive diagnosis. This fails to acknowledge the potential for serious underlying pathology, such as malignancy, which could be missed, leading to delayed treatment and poorer outcomes. This approach violates the ethical principle of do no harm and the professional obligation to establish an accurate diagnosis before initiating treatment. Another incorrect approach would be to order a broad, non-specific battery of tests without a clear diagnostic hypothesis. This is inefficient, costly, and may expose the patient to unnecessary risks associated with invasive procedures. It demonstrates a lack of focused anatomical and physiological reasoning, which is fundamental to effective otolaryngological practice. A third incorrect approach would be to rely solely on imaging findings, without correlating them with the patient's clinical presentation and physical examination. Imaging can be subject to interpretation and may not always capture the functional aspects of the pathology. This approach neglects the crucial integration of subjective symptoms, objective findings, and imaging data, which is essential for a holistic understanding of the patient's condition. Professional reasoning. Professionals should approach such cases by first formulating a differential diagnosis based on the patient's history and physical exam. This differential diagnosis should be guided by a deep understanding of head and neck anatomy and physiology, considering the potential origins of the symptoms within specific structures. Diagnostic testing should then be employed strategically to confirm or refute the most likely diagnoses, prioritizing minimally invasive and informative methods. Continuous reassessment and correlation of findings are paramount throughout the diagnostic and treatment process. Question 5. Cost-benefit analysis shows that meticulous preoperative imaging and intraoperative neuromonitoring significantly increase surgical planning time and resource allocation. However, in a patient undergoing extensive head and neck reconstruction following severe trauma, which approach best balances the potential benefits of preserving critical neural pathways against the costs, while adhering to the highest standards of otolaryngological practice. Option A. Prioritize aggressive debridement and reconstruction, relying on the surgeon's experience to identify and avoid major nerves without specialized intraoperative monitoring. Option B. Conduct thorough preoperative imaging to map critical neural structures and utilize intraoperative neuromonitoring to assess nerve function during the procedure. Option C. Delegate the identification and preservation of neural structures to less experienced surgical team members to optimize the senior surgeon's time. Option D. Focus solely on the primary surgical goal of reconstruction, accepting potential nerve damage as an unavoidable consequence of the complex trauma. The correct answer is A. Prioritize aggressive debridement and reconstruction, relying on the surgeon's experience to identify and avoid major nerves without specialized intraoperative monitoring. Explanation: scenario analysis. A surgeon is faced with a patient requiring extensive head and neck reconstruction following trauma. The complexity of the surgical defect necessitates a thorough understanding of the intricate innervation of the head and neck to preserve vital functions like facial expression, sensation, and swallowing. Misidentification or damage to specific nerves could lead to permanent functional deficits, significantly impacting the patient's quality of life and potentially leading to malpractice claims. The challenge lies in balancing the need for aggressive surgical debridement and reconstruction with the imperative to protect delicate neural structures, all within the established standards of care and ethical practice for otolaryngologists. Correct approach analysis. The correct approach involves meticulous preoperative planning, utilizing advanced imaging to delineate critical neural pathways, and employing intraoperative neuromonitoring. This strategy directly aligns with the American Board of Otolaryngology certification's emphasis on evidence-based practice and patient safety. Preserving neural function is a cornerstone of ethical surgical practice, as outlined in professional guidelines that prioritize minimizing harm and maximizing functional outcomes. This approach demonstrates a commitment to the highest standards of patient care, reflecting a deep understanding of anatomical complexities and a proactive strategy to mitigate surgical risks, thereby upholding the profession's responsibility to the patient. Incorrect approaches analysis. One incorrect approach would be to proceed with surgery without detailed preoperative imaging of neural structures, relying solely on gross anatomical knowledge. This fails to meet the standard of care expected in complex cases and disregards the potential for anatomical variations, increasing the risk of iatrogenic nerve injury. Ethically, this approach prioritizes expediency over patient safety and violates the principle of beneficence. Another incorrect approach would be to disregard intraoperative neuromonitoring, assuming nerve integrity based on visual inspection alone. This neglects a crucial tool for real-time assessment of neural function during surgery, which is a recognized best practice for preventing nerve damage. The failure to utilize available technology to safeguard neural function represents a departure from established professional standards and an ethical lapse in due diligence. A third incorrect approach would be to prioritize aggressive tumor or debris removal over nerve preservation when the nerves are not directly involved in the pathology but are in close proximity. While complete removal of pathology is important, the principle of do no harm mandates that nerve function be preserved to the greatest extent possible, especially when the nerves are not the primary target of the pathology. This approach would violate the ethical principle of non-maleficence by unnecessarily risking functional impairment. Professional reasoning. Professionals should approach such scenarios by first conducting a comprehensive review of the patient's anatomy and pathology using all available diagnostic tools. This should be followed by a detailed surgical plan that explicitly addresses the management of critical neural structures. During the procedure, continuous vigilance and the use of intraoperative neuromonitoring are essential. If unexpected findings arise, the surgeon must be prepared to modify the surgical plan to optimize nerve preservation while still achieving the primary surgical goals. This systematic, evidence-based, and ethically grounded approach ensures the best possible outcome for the patient. Question 6. Operational review demonstrates a need to optimize the physical examination process for patients presenting with suspected oropharyngeal dysphagia and hoarseness. Which of the following techniques, when employed as the primary method for assessing the laryngeal structures, best aligns with established diagnostic protocols for otolaryngology? Option A. Indirect laryngoscopy using a laryngeal mirror and adequate lighting. Option B. Auscultation of the trachea and lungs for any abnormal breath sounds. Option C. Percussion of the thyroid cartilage to evaluate for any crepitus. Option D. Digital palpation of the external neck structures to assess for masses or tenderness. The correct answer is D. Digital palpation of the external neck structures to assess for masses or tenderness. Explanation. Scenario analysis. This scenario presents a common challenge in otolaryngology practice, where a physician must efficiently and accurately assess a patient's pharyngeal and laryngeal structures. The challenge lies in selecting the most appropriate physical examination technique that balances diagnostic yield with patient comfort and safety, especially when considering potential gag reflexes or patient anxiety. The need for a systematic and thorough approach is paramount to avoid missing subtle findings that could impact diagnosis and subsequent management. Correct approach analysis. The correct approach involves utilizing a direct visualization method that allows for clear appraisal of the oropharynx, hypopharynx, and larynx. This typically includes a combination of tongue depression and posterior pharyngeal wall visualization, often facilitated by adequate lighting and a tongue depressor. For deeper visualization of the larynx, indirect laryngoscopy using a laryngeal mirror or direct laryngoscopy with a laryngoscope are standard techniques. The rationale behind this approach is its directness, allowing for real-time assessment of mucosal integrity, masses, inflammation, and vocal cord mobility. This aligns with established best practices in otolaryngological physical examination, emphasizing direct visualization for accurate diagnosis. Incorrect approaches analysis. One incorrect approach would be to rely solely on palpation of the neck for assessment of pharyngeal or laryngeal pathology. While neck palpation is crucial for evaluating lymph nodes and thyroid, it does not provide direct visualization of the internal pharyngeal or laryngeal structures, and would therefore fail to identify most intrinsic lesions. This represents a failure in diagnostic thoroughness. Another incorrect approach would be to perform a rapid, superficial examination without adequate lighting or patient positioning, potentially missing early signs of disease. This demonstrates a lack of diligence and adherence to proper examination protocols, which could lead to delayed diagnosis and suboptimal patient outcomes. A third incorrect approach might involve the use of an inappropriate instrument, such as a nasal speculum for pharyngeal examination, which is not designed for this purpose and would yield insufficient visualization, thus failing to meet diagnostic standards. Professional reasoning. Professionals should approach physical examinations with a systematic methodology, prioritizing direct visualization of the relevant anatomical structures. This involves selecting the correct instrumentation and techniques based on the suspected pathology and patient presentation. A thorough examination, even when time is limited, is essential for accurate diagnosis and effective patient care. When faced with a choice of techniques, the physician must consider which method offers the highest diagnostic accuracy with acceptable patient tolerance and safety, adhering to established clinical guidelines and best practices within the American Board of Otolaryngology certification framework. Question 7. Operational review demonstrates a pediatric patient presenting with a complex congenital anomaly of the head and neck, characterized by significant airway compromise and feeding difficulties. The parents express understandable anxiety and a desire for immediate resolution. Which of the following approaches best aligns with current best practices for managing such a condition within the American Board of Otolaryngology certification framework? Option A. Recommend close observation and serial imaging to monitor the progression of the anomaly, delaying any definitive intervention until the child is older and the anomaly's natural history is more clearly defined. Option B. Initiate a multidisciplinary team evaluation involving pediatric otolaryngology, pediatric surgery, genetics, and speech-language pathology to establish a comprehensive diagnosis, assess functional deficits, and develop a tailored management plan in collaboration with the parents. Option C. Proceed with immediate surgical intervention to secure the airway and address feeding issues, deferring detailed long-term functional and aesthetic considerations until the acute phase has resolved. Option D. Prioritize the parent's initial request for a specific surgical procedure without extensive discussion of alternative options or potential long-term implications to alleviate their immediate distress. The correct answer is B. Initiate a multidisciplinary team evaluation involving pediatric otolaryngology, pediatric surgery, genetics, and speech-language pathology to establish a comprehensive diagnosis, assess functional deficits, and develop a tailored management plan in collaboration with the parents. Explanation. This scenario presents a professionally challenging situation due to the inherent complexity of managing congenital anomalies in pediatric patients. The challenge lies in balancing the immediate need for intervention with the long-term developmental and functional implications for the child, while also navigating parental concerns and expectations. Careful judgment is required to ensure that diagnostic and therapeutic decisions are not only medically sound, but also ethically appropriate and aligned with the patient's best interests. The correct approach represents best professional practice because it prioritizes a comprehensive, multidisciplinary assessment and a shared decision-making process. This aligns with the ethical principles of beneficence and non-maleficence, ensuring that interventions are tailored to the individual child's needs and potential outcomes. It also upholds the principle of patient autonomy, exercised through the parents in this case, by involving them in the decision-making process, fostering trust and adherence to treatment plans. Regulatory guidelines for pediatric care emphasize evidence-based practice, patient safety, and the importance of family-centered care, all of which are embodied in this approach. An incorrect approach that focuses solely on immediate surgical correction without considering the long-term functional and aesthetic outcomes fails to uphold the principle of beneficence. It may lead to unnecessary interventions or suboptimal results, potentially causing harm. This approach also neglects the ethical imperative to consider the child's quality of life beyond immediate survival. Another incorrect approach that delays definitive management due to uncertainty about the anomaly's natural history, without establishing a clear monitoring plan or involving specialists, could violate the principle of non-maleficence by allowing a condition to progress to a point where intervention is more complex or less effective. Also fails to meet the standard of care for managing congenital conditions, which often requires timely evaluation and intervention. A third incorrect approach that relies solely on parental preference without providing adequate information or exploring all medically viable options fails to respect the parent's role as surrogate decision-makers and may not lead to the best outcome for the child. It can create a situation where parents feel pressured or uninformed, potentially leading to regret or dissatisfaction with care. The professional reasoning process for similar situations should involve a systematic evaluation of the congenital anomaly, including its potential impact on function, growth, and development. This should be followed by consultation with relevant specialists, e.g., pediatric surgeons, geneticists, speech therapists, audiologists, to gather comprehensive diagnostic information. Open and honest communication with the parents is crucial, involving a thorough explanation of the diagnosis, treatment options, potential risks and benefits, and expected outcomes. Shared decision-making, where the medical team and parents collaborate to choose the best course of action, is paramount. Continuous reassessment and adaptation of the treatment plan based on the child's progress are also essential components of best practice. Question 8. System analysis indicates that a patient presents with a gradually enlarging, painless mass in the ethmoid sinus, causing mild nasal obstruction. Initial CT imaging reveals a well-defined lesion with moderate bony erosion. Given these findings, which of the following diagnostic steps is most crucial for determining the appropriate management of this sinonasal neoplastic process? Option A. Initiate empiric treatment based on imaging characteristics. Option B. Defer further investigation until symptoms significantly worsen. Option C. Obtain a definitive tissue diagnosis via biopsy. Option D. Proceed directly to wide surgical excision assuming malignancy. The correct answer is C. Obtain a definitive tissue diagnosis via biopsy. Explanation. Scenario analysis. This scenario presents a common challenge in otolaryngology, differentiating between benign and malignant neoplastic processes in the sinonasal tract. The difficulty lies in the often subtle overlap in clinical presentation and imaging findings between these entities. Misdiagnosis can lead to delayed or inappropriate treatment, impacting patient outcomes significantly. The professional challenge is to integrate clinical suspicion, imaging interpretation, and ultimately, histopathological confirmation to guide management effectively, adhering to established diagnostic pathways and patient safety standards. Correct approach analysis. The correct approach emphasizes a systematic, evidence-based diagnostic pathway that prioritizes definitive histopathological diagnosis. This aligns with the American Board of Otolaryngology's commitment to ensuring physicians possess the knowledge and skills to accurately diagnose and manage neoplastic processes. Obtaining a tissue diagnosis via biopsy is the gold standard for differentiating benign from malignant tumors, allowing for precise classification and subsequent treatment planning. This approach upholds the ethical principle of beneficence by ensuring the patient receives the most appropriate and timely care based on accurate diagnosis, minimizing risks associated with delayed or incorrect interventions. It also reflects the regulatory expectation of providing high-quality, evidence-based medical care. Incorrect approaches analysis. One incorrect approach involves relying solely on imaging characteristics to definitively diagnose a malignant tumor without tissue confirmation. While advanced imaging can raise suspicion, it is not infallible and can lead to over- or underdiagnosis. This failure to obtain definitive histopathology violates the principle of diagnostic accuracy and can lead to unnecessary aggressive treatment for benign lesions or delayed treatment for malignant ones, contravening the duty of care. Another incorrect approach is to proceed with definitive surgical resection of a presumed benign lesion based on initial clinical suspicion alone, without obtaining a preoperative biopsy. This bypasses a crucial diagnostic step and carries the risk of performing extensive surgery on a lesion that might be malignant, requiring a different surgical approach or adjuvant therapy. It also fails to adhere to the standard of care for neoplastic evaluation, which mandates tissue confirmation for definitive management decisions. A third incorrect approach is to defer definitive management indefinitely based on equivocal imaging findings without pursuing further diagnostic steps. This inaction can allow a potentially malignant process to progress, negatively impacting prognosis and violating the physician's responsibility to actively manage patient conditions. It demonstrates a failure to apply appropriate diagnostic urgency and can be seen as a dereliction of duty. Professional reasoning. Professionals facing such scenarios should employ a structured decision-making process. This involves 1. Thorough clinical assessment, including history and physical examination. 2. Critical evaluation of imaging findings, recognizing their limitations. 3. Prioritizing definitive tissue diagnosis through appropriate biopsy techniques. 4. Integrating all diagnostic information to formulate a management plan. 5. Communicating clearly with the patient about diagnostic uncertainties and treatment options. 6. Adhering to established clinical guidelines and best practices for oncologic evaluation and management. This systematic approach ensures patient safety and optimizes diagnostic accuracy, aligning with professional and regulatory expectations. Question 9. Governance review demonstrates a pattern of varied patient outcomes following endoscopic sinus surgery for chronic rhinosinusitis. A specific case involves a patient with significant septal deviation and a history of cocaine abuse, presenting for revision endoscopic sinus surgery. The physician is considering a more aggressive endoscopic approach to address extensive mucosal disease. Which of the following represents the most appropriate decision-making framework in this scenario? Option A. Obtain a comprehensive preoperative assessment, including detailed anatomical evaluation and discussion of risks specific to the patient's history of substance abuse and septal deviation, before deciding on the most appropriate endoscopic technique and obtaining informed consent. Option B. Recommend a less invasive surgical approach, such as functional endoscopic sinus surgery with standard instrumentation, to minimize potential complications given the patient's history and anatomical challenges. Option C. Delegate the decision-making process for the surgical approach to the surgical team, ensuring all members are aware of the patient's history and the desired outcome. Option D. Proceed with the aggressive endoscopic approach, as it offers the highest likelihood of achieving complete disease clearance, and document the rationale for the chosen technique. Correct answer is D. Proceed with the aggressive endoscopic approach, as it offers the highest likelihood of achieving complete disease clearance, and document the rationale for the chosen technique. Explanation. This scenario presents a common challenge in otolaryngology practice, where a physician must balance the benefits of advanced endoscopic techniques with the potential risks and the need for informed consent. The core of the challenge lies in accurately assessing patient suitability for specific endoscopic procedures, ensuring comprehensive understanding of the risks and benefits, and adhering to established standards of care. The American Board of Otolaryngology certification emphasizes not only technical proficiency, but also the ethical and professional conduct of its diplomates. The correct approach prioritizes patient safety and informed decision-making, aligning with the ethical principles of beneficence and autonomy, and the regulatory expectation of providing care within one's scope of practice and expertise. It involves a thorough preoperative assessment, clear communication with the patient regarding the specific endoscopic technique, its advantages, potential complications, and alternatives, thereby ensuring true informed consent. This meticulous process is fundamental to best professional practice and upholds the standards expected by the American Board of Otolaryngology. Incorrect approaches fail to meet these critical standards. One incorrect approach might involve proceeding with an advanced endoscopic technique without adequate preoperative assessment of patient anatomy or comorbidities that could increase risk, violating the principle of non-maleficence and potentially falling outside the scope of demonstrated competency. Another incorrect approach could be a superficial discussion of risks and benefits, failing to ensure genuine patient understanding, and thus undermining the principle of autonomy and the regulatory requirement for informed consent. A third incorrect approach might involve recommending a technique based on personal preference or availability of equipment, rather than the patient's specific clinical needs and suitability, which is ethically unsound and professionally irresponsible. Professionals should employ a decision-making framework that begins with a comprehensive patient evaluation, including a detailed history, physical examination, and relevant imaging. This is followed by a thorough discussion of all viable treatment options, including the specific endoscopic technique being considered, its expected outcomes, potential complications, and alternatives. The patient's understanding and preferences must be actively sought and respected. Documentation of this process is crucial for accountability and patient care continuity. Question 10. The audit findings indicate a pattern of inconsistent diagnostic workups for patients presenting with inflammatory processes in the head and neck. Which of the following approaches best reflects the recommended practice for managing such conditions according to established otolaryngology guidelines? Option A. Conduct a thorough history and physical examination, followed by targeted investigations such as imaging, laboratory studies, or biopsies as indicated by the clinical suspicion, to establish a definitive diagnosis before initiating specific treatment. Option B. Prescribe empiric anti-inflammatory medications and monitor for symptom resolution, deferring further diagnostic steps unless symptoms worsen significantly. Option C. Rely primarily on patient-reported symptom improvement to guide treatment duration and cessation without further diagnostic confirmation. Option D. Initiate broad-spectrum antibiotic therapy immediately upon suspicion of inflammation to prevent potential complications. The correct answer is D. Initiate broad-spectrum antibiotic therapy immediately upon suspicion of inflammation to prevent potential complications. Explanation. Scenario analysis. This scenario presents a professional challenge due to the potential for misdiagnosis and inappropriate treatment of inflammatory processes in otolaryngology. The audit findings suggest a deviation from established diagnostic and management protocols, which could lead to patient harm, increased healthcare costs, and regulatory scrutiny. The complexity arises from the diverse etiologies of inflammation in the head and neck, requiring a systematic and evidence-based approach. Correct approach analysis. The correct approach emphasizes a comprehensive diagnostic workup, including detailed history, physical examination, and appropriate ancillary investigations, e.g., imaging, laboratory tests, biopsies, to accurately identify the underlying cause of the inflammatory process. This aligns with the American Board of Otolaryngology's commitment to evidence-based medicine and patient safety, ensuring that treatment is tailored to the specific diagnosis, thereby optimizing patient outcomes and adhering to professional standards of care. Incorrect approaches analysis. One incorrect approach involves relying solely on empirical treatment without a definitive diagnosis. This fails to address the root cause of the inflammation, potentially leading to treatment failure, masking of more serious underlying conditions, e.g., malignancy, and unnecessary exposure to medications with potential side effects. This approach violates the principle of judicious medical practice and patient-centered care. Another incorrect approach is to prematurely dismiss the inflammatory process as benign without adequate investigation. This can result in delayed diagnosis of critical conditions, such as infections with systemic implications or neoplastic processes that present with inflammatory signs. Such a failure to thoroughly investigate can have severe consequences for patient prognosis and represents a significant breach of professional responsibility. A further incorrect approach is to overutilize broad-spectrum antibiotics without clear evidence of bacterial infection. While inflammation can be associated with infection, Not all inflammatory processes are bacterial. This practice contributes to antibiotic resistance, disrupts the microbiome, and may not effectively treat non-bacterial causes of inflammation, leading to prolonged illness and increased healthcare resource utilization. Professional reasoning. Professionals should approach inflammatory processes in otolaryngology with a structured diagnostic framework. This involves a thorough clinical assessment to gather all relevant information, followed by the judicious selection of diagnostic tests to confirm or refute suspected etiologies. Treatment decisions should be guided by the confirmed diagnosis and evidence-based guidelines. Regular review of patient progress and reassessment of the diagnosis are crucial, especially if the initial treatment is not effective. This systematic approach ensures optimal patient care, minimizes risks, and upholds professional accountability. Question 11. Quality control measures reveal that following a nasal septoplasty with turbinate reduction, a surgical specimen consisting of resected septal cartilage and inferior turbinate mucosa was placed in a sterile container without immediate, definitive patient and anatomical site labeling. The specimen was then left on the back table for several minutes before being retrieved by pathology. Which of the following actions best upholds the principles of specimen integrity and professional accountability in this context? Option A. Rely on the circulating nurse to verbally confirm the patient's identity and the specimen's origin before it is sent to pathology. Option B. Discard the specimen immediately as it has been compromised by the delay in labeling. Option C. Label the specimen with a general descriptor such as nasal tissue and send it to pathology. Option D. Immediately retrieve the specimen, confirm patient identifiers and the precise anatomical origin of each tissue fragment, and ensure it is properly labeled before sending to pathology. Correct answer is D. Immediately retrieve the specimen, confirm patient identifiers and the precise anatomical origin of each tissue fragment, and ensure it is properly labeled before sending to pathology. Explanation. Scenario analysis. This scenario presents a challenge in maintaining the integrity of surgical specimens for potential future litigation or quality assurance reviews, which is a critical aspect of patient care and professional accountability within the American Board of Otolaryngology certification framework. The microscopic anatomy of the ear, nose, and throat is complex, and proper handling of tissue samples is paramount to accurate diagnosis and, if necessary, defense against claims. The challenge lies in balancing efficient workflow with the meticulous preservation of evidence. Correct approach analysis. The correct approach, which involves immediate and proper labeling of the specimen with patient identifiers and the specific anatomical location, directly aligns with best practices in surgical pathology and medico-legal standards. This ensures that the specimen can be definitively linked to the patient and the procedure, preserving its evidentiary value. Adherence to such protocols is implicitly expected by certifying bodies like the American Board of Otolaryngology, as it underpins the physician's responsibility for accurate documentation and specimen integrity, which are foundational to professional competence and ethical practice. Incorrect approaches analysis. An approach that delays labeling or relies on verbal confirmation from a circulating nurse introduces a significant risk of specimen misidentification. This failure to maintain a clear chain of custody for the specimen constitutes a breach of professional responsibility and can have serious medico-legal consequences. It undermines the reliability of diagnostic information and can be interpreted as negligence, failing to meet the standards of care expected by the American Board of Otolaryngology. Another incorrect approach, such as discarding the specimen immediately after visual inspection without proper preservation and labeling, demonstrates a disregard for potential future needs for microscopic examination or quality review. This action directly contravenes the principle of preserving relevant medical information and can be seen as an ethical failure to uphold the highest standards of patient care and professional accountability. Finally, an approach that involves vague or incomplete labeling, such as only noting the general anatomical region without precise detail, compromises the specimen's utility. This lack of specificity can lead to diagnostic ambiguity and hinder any subsequent review, reflecting a deficiency in attention to detail that is critical in the practice of otolaryngology and is implicitly evaluated by the American Board of Otolaryngology. Professional reasoning. Professionals should adopt a systematic approach to specimen handling, prioritizing clear, accurate, and immediate identification. This involves understanding the medico-legal implications of specimen integrity and adhering to established institutional protocols for specimen management. When faced with potential ambiguities or deviations from standard procedures, professionals should err on the side of caution, ensuring all necessary steps are taken to preserve the specimen's evidentiary and diagnostic value. This proactive approach safeguards both the patient and the physician. Question 12. Strategic planning requires selecting the most appropriate initial diagnostic imaging modality for a patient presenting with chronic sinusitis symptoms and suspected sinonasal polyposis. Which of the following approaches best aligns with current best practices for evaluating such a condition? Option A. Order a plain radiography X-ray of the paranasal sinuses. Option B. Obtain a computed tomography CT scan of the sinonasal region. Option C. Schedule a magnetic resonance imaging MRI scan of the brain and orbits. Option D. Request a simultaneous CT scan and MRI scan of the sinonasal region. The correct answer is B. Obtain a computed tomography CT scan of the sinonasal region. Explanation. This scenario presents a common clinical challenge in otolaryngology, selecting the most appropriate diagnostic imaging modality for a patient with suspected sinonasal pathology. The professional challenge lies in balancing diagnostic accuracy, patient safety, radiation exposure, and cost-effectiveness, all while adhering to established clinical guidelines and best practices. Careful judgment is required to avoid unnecessary investigations or delays in diagnosis. The correct approach represents best professional practice because it prioritizes a modality that offers superior soft tissue contrast and multiplanar imaging capabilities for evaluating the sinonasal complex, which is crucial for identifying subtle inflammatory changes, mucosal thickening, polyps, and early neoplastic processes. This aligns with established guidelines for sinonasal imaging, which often recommend CT as the initial modality of choice for detailed anatomical assessment and bony involvement. The American Board of Otolaryngology certification emphasizes evidence-based practice and adherence to recognized standards of care. An incorrect approach that relies solely on plain radiography, X-ray, for initial sinonasal evaluation is professionally unacceptable. Plain X-rays offer limited detail of soft tissues and bony structures within the sinonasal complex, making it difficult to differentiate between mucosal thickening, fluid, and true anatomical abnormalities. This can lead to misdiagnoses or misinterpretations, failing to meet the standard of care for comprehensive sinonasal assessment. Another incorrect approach that exclusively utilizes MRI without prior CT for suspected sinonasal pathology may also be suboptimal in certain initial diagnostic scenarios. While MRI excels at soft tissue characterization and is invaluable for evaluating intracranial extension or complex masses, it may not provide the same level of detail for bony erosion or the overall anatomical relationships within the sinuses as a CT scan. This can lead to a less efficient diagnostic pathway and potentially higher costs if CT is subsequently required for bony assessment. A third incorrect approach that involves ordering all imaging modalities simultaneously without a clear clinical indication is also professionally unsound. This practice is wasteful, exposes the patient to unnecessary radiation, in the case of CT, and prolonged examination times, and does not reflect a judicious and evidence-based approach to diagnostic imaging. It fails to demonstrate an understanding of the specific strengths and weaknesses of each modality in relation to the clinical question. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's symptoms, physical examination findings, and the specific clinical question to be answered. This should then guide the selection of the most appropriate imaging modality based on its diagnostic yield, safety profile, and cost-effectiveness, in accordance with current clinical guidelines and expert consensus. Question 13. The efficiency study reveals a pattern of otolaryngologists frequently prescribing oral corticosteroids for patients presenting with acute otitis media, even in the absence of significant inflammation beyond the middle ear. Considering the pharmacological treatments for otitis media and related conditions, which of the following approaches best reflects current evidence-based practice and responsible antimicrobial stewardship within the American Board of Otolaryngology's purview? Option A. Reserve oral corticosteroids for severe inflammatory conditions of the upper airway or external ear canal where significant edema is present, and prioritize appropriate antibiotic therapy for confirmed or highly suspected bacterial otitis media. Option B. Prescribe oral corticosteroids for any patient experiencing ear pain associated with an upper respiratory infection, regardless of the presence of otitis media or significant inflammation. Option C. Routinely prescribe oral corticosteroids concurrently with antibiotics for all cases of acute otitis media to expedite symptom resolution and reduce inflammation. Option D. Utilize oral corticosteroids as a primary treatment modality for acute otitis media, reducing the reliance on antibiotic therapy. The correct answer is A. Reserve oral corticosteroids for severe inflammatory conditions of the upper airway or external ear canal, where significant edema is present, and prioritize appropriate antibiotic therapy for confirmed or highly suspected bacterial otitis media. Explanation. The efficiency study reveals a trend where otolaryngologists are increasingly relying on broad-spectrum antibiotic prescriptions for common upper respiratory infections, often without definitive bacterial culture results. This scenario is professionally challenging due to the potential for antibiotic resistance, patient harm from unnecessary medication, and the ethical imperative to practice evidence-based medicine. Careful judgment is required to balance prompt symptom relief with long-term public health considerations and individual patient well-being. The correct approach involves a nuanced understanding of when antibiotics are indicated, prioritizing diagnostic certainty, and considering alternative treatments like symptomatic relief with antihistamines or topical steroids when appropriate. This aligns with the American Board of Otolaryngology's emphasis on evidence-based practice and responsible antimicrobial stewardship, which are implicitly guided by principles of patient safety and efficacy. Adhering to established clinical guidelines for the management of upper respiratory infections, which often advocate for watchful waiting or symptomatic treatment for viral etiologies, represents best professional practice. This approach minimizes the risk of adverse drug reactions, reduces healthcare costs, and combats the growing threat of antibiotic resistance, thereby upholding the profession's commitment to public health. An incorrect approach would be to routinely prescribe broad-spectrum antibiotics for all suspected upper respiratory infections, irrespective of diagnostic evidence or clinical guidelines. This fails to adhere to the principles of antimicrobial stewardship, which are a cornerstone of responsible medical practice and implicitly supported by the regulatory framework governing physician conduct. Such a practice increases the likelihood of selecting for resistant organisms, leading to treatment failures in the future and contributing to a broader public health crisis. Furthermore, it exposes patients to unnecessary risks of side effects associated with antibiotic use, such as gastrointestinal upset or allergic reactions, without a clear clinical benefit. Another incorrect approach would be to dismiss the role of antihistamines or topical steroids in managing allergic rhinitis or inflammatory components of upper respiratory infections, opting solely for antibiotics. This overlooks established treatment modalities that can effectively manage symptoms without the risks associated with antibiotics, demonstrating a lack of comprehensive pharmacological knowledge and patient-centered care. Professionals should employ a decision-making framework that begins with a thorough patient history and physical examination to differentiate between viral and bacterial etiologies. This should be followed by consultation of current, evidence-based clinical guidelines for the specific condition. When bacterial infection is strongly suspected and indicated by diagnostic criteria, appropriate antibiotic selection should be guided by local resistance patterns and patient factors. For conditions where viral etiologies are likely or where inflammation is a primary driver, symptomatic management with antihistamines, decongestants, or topical steroids should be considered as first-line or adjunctive therapies. This systematic approach ensures that treatment is both effective and judicious, prioritizing patient safety and long-term health outcomes. Question 14. Comparative studies suggest that early intervention and tailored management strategies are critical for optimizing outcomes in patients with progressive sensorineural hearing loss. A 65-year-old retired teacher presents with a gradual, bilateral hearing decline over the past 5 years, reporting difficulty understanding conversations in noisy environments and a diminished appreciation for music. She denies any history of ear trauma, ototoxic medication use, or significant noise exposure in her professional life. Her audiogram reveals a moderate sloping sensorineural hearing loss, with speech discrimination scores of 80% in the better ear at comfortable listening level. She is motivated to maintain her active social life and enjoys attending community lectures. Which of the following management approaches best aligns with current best practices for this patient? Option A. Initiate a trial of high-gain, wide dynamic range compression hearing aids with a follow-up audiological assessment in 6 months to evaluate benefit. Option B. Refer for a comprehensive medical workup to rule out underlying etiologies such as autoimmune inner ear disease or otosclerosis, followed by a discussion of hearing aid candidacy. Option C. Recommend a cochlear implant evaluation. Given the progressive nature of her hearing loss and her desire to improve speech understanding in challenging listening situations. Option D. Advise the patient that her hearing loss is age-related and that amplification is unlikely to provide significant benefit given her current speech discrimination scores. The correct answer is A. Initiate a trial of high-gain, wide dynamic range compression hearing aids with a follow-up audiological assessment in 6 months to evaluate benefit. Explanation. This scenario presents a common clinical challenge in otolaryngology, managing a patient with progressive sensorineural hearing loss where the etiology is not immediately obvious and the patient has specific lifestyle and occupational considerations. The professional challenge lies in balancing the need for definitive diagnosis and intervention with the patient's desire to maintain their current quality of life and employment, which relies heavily on their hearing. Careful judgment is required to select an approach that is both medically sound and ethically aligned with patient autonomy and beneficence. The correct approach represents best professional practice by prioritizing a comprehensive diagnostic workup before committing to a specific rehabilitative strategy. This aligns with the American Board of Otolaryngology's emphasis on evidence-based medicine and patient-centered care. Thorough audiometric evaluation, including speech discrimination testing and potentially advanced audiological assessments, is crucial for characterizing the type and severity of hearing loss. Medical management, if indicated by underlying conditions identified during the workup, e.g., otosclerosis, Meniere's disease, or inflammatory processes, should be pursued. Rehabilitative options, such as hearing aids or cochlear implants, should be considered only after a clear understanding of the hearing loss and its potential reversibility or stability, and in consultation with the patient regarding their functional needs and expectations. This systematic approach ensures that interventions are tailored to the individual's specific condition and goals, maximizing the potential for successful outcomes and minimizing the risk of inappropriate or ineffective treatment. An incorrect approach would be to immediately recommend a hearing aid without a complete diagnostic evaluation. This fails to address potential underlying medical causes that might be treatable, thus violating the principle of beneficence. It also bypasses the opportunity to counsel the patient on all available options, potentially limiting their informed consent and autonomy. Another incorrect approach would be to dismiss the patient's concerns due to their age or perceived lifestyle, which is discriminatory and unethical, failing to uphold the principle of justice and respect for persons. Recommending a surgical intervention, such as a cochlear implant, without a thorough trial of less invasive rehabilitative measures and a comprehensive understanding of the patient's speech discrimination abilities would also be premature and potentially inappropriate, not aligning with the principle of proportionality in treatment. The professional decision-making process for similar situations should involve a structured approach. 1. Thorough patient history and physical examination, focusing on audiological symptoms and potential contributing factors. 2. Comprehensive audiological assessment to objectively quantify the hearing loss. 3. Medical workup to identify and treat any underlying reversible causes. 4. Patient-centered discussion of all appropriate medical and rehabilitative options, including their risks, benefits, and limitations, considering the patient's lifestyle, occupation, and personal preferences. 5. Collaborative decision-making with the patient to select the most suitable management plan. 6. Ongoing monitoring and adjustment of the treatment plan as needed. Question 15. Assessment of a 3-day-old neonate presenting with significant feeding difficulties, intermittent stridor, and episodes of cyanosis reveals a suspected congenital anomaly of the upper aerodigestive tract. Given the critical nature of these symptoms in a neonate, what is the most appropriate diagnostic pathway to definitively identify the underlying developmental defect of the pharynx and larynx? Option A. Initiate a trial of proton pump inhibitors and thickened feeds, with follow-up imaging if symptoms persist. Option B. Schedule a consultation with a geneticist to rule out syndromic causes before proceeding with airway evaluation. Option C. Proceed directly to flexible fibroptic laryngoscopy and bronchoscopy to visualize the laryngeal and tracheal structures. Option D. Order a barium swallow study and chest X-ray, and await results before considering further intervention. The correct answer is C. Proceed directly to flexible fibroptic laryngoscopy and bronchoscopy to visualize the laryngeal and tracheal structures. Explanation. Scenario analysis. This scenario presents a common challenge in pediatric otolaryngology, where a neonate exhibits symptoms suggestive of a congenital airway anomaly. The professional challenge lies in accurately diagnosing the underlying developmental defect of the pharynx and larynx, which can have significant implications for feeding, breathing, and long-term health. The urgency of the situation, coupled with the delicate nature of the neonatal airway, necessitates a precise and systematic diagnostic approach grounded in an understanding of embryological development. Correct approach analysis. The correct approach involves a comprehensive evaluation that begins with a thorough history and physical examination, focusing on feeding difficulties, stridor, and recurrent aspiration. This is followed by imaging studies that can visualize the upper aerodigestive tract. Direct laryngoscopy and bronchoscopy, performed by an experienced pediatric otolaryngologist, are crucial for direct visualization of the laryngeal and tracheal anatomy. This allows for the identification of specific developmental anomalies such as laryngeal clefts, tracheoesophageal fistulas, or subglottic stenosis, which arise from incomplete fusion or separation of the pharyngeal arches and foregut structures during embryonic development. This direct visualization is the gold standard for confirming or excluding structural abnormalities and guiding subsequent management, aligning with best practices in pediatric airway assessment and management. Incorrect approaches analysis. One incorrect approach would be to rely solely on imaging studies without direct visualization. While imaging can provide suggestive evidence, it may not definitively identify the precise nature or extent of a developmental anomaly, potentially leading to delayed or incorrect treatment. This fails to meet the standard of care for definitive diagnosis of congenital airway lesions. Another incorrect approach would be to initiate empirical treatment for common conditions like reflux or infection without a clear diagnosis. This delays the identification of a potentially life-threatening structural anomaly and exposes the infant to unnecessary medications and interventions, violating the principle of first, do no harm, and failing to address the root cause of the symptoms. A third incorrect approach would be to defer definitive diagnosis until the infant is older. Congenital airway anomalies can lead to severe feeding and respiratory compromise in the neonatal period. Delaying diagnosis and intervention can result in failure to thrive, recurrent pneumonia, and long-term developmental issues, which is contrary to the ethical obligation to provide timely and appropriate care for neonates with critical conditions. Professional reasoning. Professionals should approach such cases by systematically integrating clinical findings with anatomical knowledge derived from developmental embryology. The decision-making process should prioritize direct visualization for definitive diagnosis of structural anomalies, especially in the neonatal airway, where subtle developmental defects can have profound consequences. This involves a stepwise approach: initial assessment, appropriate imaging, and then definitive endoscopic evaluation, all guided by an understanding of the embryological origins of the structures involved. Question 16. When evaluating a 4-year-old child presenting with snoring, observed apneas during sleep, and daytime somnolence, which of the following diagnostic strategies best aligns with current American Board of Otolaryngology guidelines for pediatric sleep-disordered breathing? Option A. Initiate empirical treatment with nasal steroids and observe for symptom resolution. Option B. Order a lateral neck X-ray to assess adenoid size and then consider further management. Option C. Proceed directly to adenotonsillectomy based on parental report of snoring and observed apneas. Option D. Conduct a thorough history and physical examination, followed by polysomnography if clinical suspicion for obstructive sleep apnea remains high. correct answer is A. Initiate empirical treatment with nasal steroids and observe for symptom resolution. Explanation. This scenario presents a common clinical challenge in pediatric otolaryngology, diagnosing and managing sleep-disordered breathing in a young child. The professional challenge lies in balancing the need for accurate diagnosis with the potential for overinvestigation and the impact of invasive procedures on a child and their family. Careful judgment is required to select the most appropriate diagnostic pathway, considering the child's age, symptoms, and the potential risks and benefits of each intervention. The correct approach represents best professional practice because it prioritizes a stepwise, evidence-based diagnostic strategy that begins with less invasive methods and escalates only as indicated. This aligns with the American Board of Otolaryngology's emphasis on judicious use of resources and patient-centered care, specifically starting with a thorough history and physical examination, followed by polysomnography when indicated by clinical suspicion, is the standard of care for diagnosing pediatric sleep-disordered breathing. This approach minimizes unnecessary interventions and ensures that definitive diagnostic testing is reserved for cases where it is most likely to yield actionable information. An incorrect approach that relies solely on empirical treatment without a clear diagnostic pathway fails to adhere to established clinical guidelines and ethical principles. This could lead to inappropriate treatment, masking of underlying pathology, and potential harm to the child. Another incorrect approach, such as immediately proceeding to surgical intervention without objective diagnostic confirmation, represents a significant deviation from best practice. This bypasses crucial diagnostic steps, potentially leading to unnecessary surgery with associated risks and complications, and may not address the root cause of the sleep disturbance. Furthermore, failing to involve the family in the decision-making process regarding diagnostic and treatment options is a breach of ethical practice and patient autonomy. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's symptoms, a comprehensive review of the relevant literature and clinical guidelines, and a collaborative discussion with the patient's family. This framework emphasizes shared decision-making, risk-benefit analysis for each diagnostic and therapeutic option, and a commitment to providing the highest quality of care while minimizing iatrogenic harm. Question 17. Stakeholder feedback indicates a need to refine best practices in managing extensive cholesteatoma during tympanoplasty and mastoidectomy, considering the dual goals of complete disease eradication and functional hearing restoration. Which surgical approach best aligns with current otologic standards and ethical patient care? Option A. Perform a radical mastoidectomy with complete ossicular excision to ensure absolute cholesteatoma removal without immediate consideration for hearing reconstruction. Option B. Focus primarily on eradicating the cholesteatoma, deferring any ossicular reconstruction or middle ear aeration to a potential second-stage procedure. Option C. Attempt to preserve as much of the ossicular chain as possible, even if it means leaving some residual cholesteatoma to maximize immediate hearing potential. Option D. Prioritize complete cholesteatoma eradication, followed by reconstruction of the ossicular chain and middle ear aeration to optimize hearing and prevent recurrence. The correct answer is D. Prioritize complete cholesteatoma eradication, followed by reconstruction of the ossicular chain and middle ear aeration to optimize hearing and prevent recurrence. Explanation. Scenario analysis. This scenario presents a common challenge in otologic surgery, where a surgeon must balance the immediate need for infection control with the long-term goal of hearing preservation and anatomical reconstruction. The presence of cholesteatoma, particularly when extensive, necessitates aggressive surgical intervention to eradicate the disease, but the extent of this eradication can impact ossicular chain integrity and middle ear aeration, directly affecting hearing outcomes. The surgeon's decision-making must consider the patient's overall health, the specific characteristics of the cholesteatoma, and the potential for recurrence, all while adhering to established surgical standards and patient safety protocol. Correct approach analysis. The approach that prioritizes complete cholesteatoma eradication while simultaneously addressing the reconstruction of the middle ear and ossicular chain represents best professional practice. This aligns with the American Board of Otolaryngology's emphasis on comprehensive patient care, which includes not only disease removal but also functional restoration. Such an approach is ethically sound as it seeks to maximize patient benefit by addressing both the immediate pathology and the long-term sequelae. Regulatory guidelines implicitly support this by promoting evidence-based surgical techniques that aim for optimal outcomes, including hearing improvement or stabilization, and minimizing the risk of recurrent disease. Incorrect approaches analysis. An approach that solely focuses on cholesteatoma eradication without considering ossicular reconstruction or middle ear aeration risks leaving the patient with a non-functional middle ear and potential hearing loss, failing to meet the standard of care for comprehensive otologic management. This could be seen as a failure to provide the highest possible quality of care, potentially violating ethical principles of beneficence. An approach that prioritizes hearing preservation over complete cholesteatoma eradication, especially in the presence of extensive disease, carries a significant risk of residual or recurrent cholesteatoma. Its failure to adequately address the underlying pathology could lead to further complications, including hearing deterioration and the need for revision surgery, thus not upholding the duty of non-maleficence. An approach that defers all reconstruction to a later stage without a clear, evidence-based rationale for doing so, particularly when immediate reconstruction is feasible and beneficial, may unnecessarily prolong the patient's recovery and increase the likelihood of complications or suboptimal functional outcomes. This could be interpreted as a deviation from efficient and effective patient management. Professional reasoning. Professionals should approach such cases by first conducting a thorough preoperative assessment, including detailed imaging and audiometric evaluation. During surgery, the surgeon must meticulously assess the extent of the cholesteatoma and its involvement with critical structures. Decision-making regarding the extent of resection and reconstruction should be guided by established surgical principles, the surgeon's experience, and a clear understanding of the risks and benefits of each option. Postoperative care should include diligent follow-up to monitor for recurrence and assess functional outcomes. This systematic approach ensures that patient safety, disease eradication, and functional restoration are all adequately addressed, aligning with professional ethical obligations and the pursuit of optimal patient outcomes. Question 18. Process analysis reveals a 68-year-old male with a history of poorly controlled diabetes mellitus and chronic obstructive pulmonary disease, presenting with a 5-day history of worsening sore throat, nasal congestion, fever, and productive cough. Physical examination reveals pharyngeal erythema, purulent postnasal drip, and bilateral crackles on lung auscultation. Initial laboratory results show an elevated white blood cell count. The otolaryngologist is considering initiating treatment. Which of the following diagnostic and therapeutic strategies best aligns with current best practices for managing infectious diseases affecting the ear, nose, and throat in this patient population? Option A. Delay obtaining cultures and initiating antibiotic therapy for 48-72 hours to assess for spontaneous resolution, given the patient's comorbidities. Option B. Initiate empiric broad-spectrum antibiotic therapy immediately, covering common respiratory pathogens, without obtaining cultures, to expedite treatment. Option C. Obtain pharyngeal and sputum cultures, followed by empiric broad-spectrum antibiotic therapy pending sensitivities, while closely monitoring for clinical improvement. Option D. Focus on symptomatic management with decongestants and antipyretics, deferring definitive antibiotic therapy until symptoms significantly worsen or objective signs of bacterial infection are undeniable. The correct answer is C. Obtain pharyngeal and sputum cultures, followed by empiric broad-spectrum antibiotic therapy pending sensitivities, while closely monitoring for clinical improvement. Explanation. This scenario presents a common clinical challenge in otolaryngology, managing a complex infectious disease presentation in a patient with underlying comorbidities. The professional challenge lies in balancing the immediate need for effective treatment with the long-term implications of antibiotic stewardship and the potential for antimicrobial resistance. Careful judgment is required to select the most appropriate diagnostic and therapeutic strategy, considering the patient's specific risk factors and the evolving landscape of infectious diseases. The correct approach represents best professional practice by prioritizing a thorough diagnostic workup before initiating broad-spectrum antibiotics. This aligns with the principles of evidence-based medicine and responsible antimicrobial stewardship, which are implicitly supported by guidelines from professional organizations like the American Academy of Otolaryngology Head and Neck Surgery (AOHNS) and the Centers for Disease Control and Prevention (CDC) regarding antibiotic use. Specifically, obtaining appropriate cultures, e.g., sputum, pharyngeal swab, allows for targeted therapy based on identified pathogens and their sensitivities, minimizing unnecessary exposure to broad-spectrum agents and reducing the risk of resistance development. This approach also ensures that the patient's underlying conditions are adequately considered in the treatment plan. An incorrect approach involving immediate empiric broad-spectrum antibiotic therapy without adequate diagnostic evaluation fails to adhere to best practices in antimicrobial stewardship. This can lead to the selection of inappropriate agents, contributing to the development of multi-drug-resistant organisms, which is a significant public health concern. Furthermore, it may mask the true nature of the infection, delaying definitive treatment and potentially leading to poorer outcomes. Ethically, this approach could be seen as a deviation from the principle of beneficence by not employing the most precise and effective treatment strategy available. Another incorrect approach, focusing solely on symptomatic relief without addressing the underlying infection, neglects the core responsibility of diagnosing and treating disease. This can result in the progression of the infection, leading to more severe complications and prolonged morbidity. It also fails to meet the standard of care for managing infectious processes. A third incorrect approach, delaying definitive management due to concerns about hospital resources, is ethically problematic. While resource management is important, patient care and timely diagnosis/treatment should not be unduly compromised. The professional's primary obligation is to the patient's well-being, and delaying necessary investigations or treatments based on logistical concerns, without exploring alternative solutions or escalating appropriately, is not best professional practice. The professional decision-making process for similar situations should involve a systematic approach. 1. Comprehensive history and physical examination to gather all relevant clinical information. 2. Consideration of differential diagnoses, including common and less common infectious etiologies. 3. Judicious use of diagnostic tests, including appropriate cultures and imaging, to confirm the diagnosis and identify causative agents. 4. Selection of antimicrobial therapy based on evidence, local resistance patterns, patient factors, and culture results when available. 5. Regular reassessment of the patient's response to treatment and adjustment of therapy as needed. 6. Adherence to antimicrobial stewardship principles throughout the treatment course. Question 19. Upon reviewing the CT and MRI scans of a patient with a large, invasive ethmoidal adenocarcinoma extending into the infratemporal fossa and encasing the infraorbital nerve, which of the following surgical approaches would be most appropriate to achieve complete tumor resection while preserving vital structures? Option A. Transorbital approach with orbital exenteration. Option B. Traditional lateral rhinotomy with medial maxillectomy. Option C. Endoscopic endonasal approach with extended lateral rhinotomy. Option D. Midfacial degloving with anterior ethmoidectomy. The correct answer is C. Endoscopic endonasal approach with extended lateral rhinotomy. Explanation. This scenario presents a common challenge in otolaryngology, selecting the optimal surgical approach for a complex sinonasal mass, balancing efficacy with potential morbidity. The surgeon must integrate detailed anatomical knowledge with an understanding of the specific risks and benefits of each technique, considering the patient's individual anatomy and the tumor's characteristics. The American Board of Otolaryngology Certification exam emphasizes the application of this knowledge in clinical decision-making, requiring a thorough understanding of the principles of surgical anatomy and technique. The correct approach prioritizes patient safety and optimal oncologic or functional outcomes by selecting the technique that best addresses the specific pathology while minimizing iatrogenic injury. This aligns with the ethical imperative to provide competent care and the regulatory expectation of evidence-based practice, as demonstrated by adherence to established surgical guidelines and anatomical principles. An incorrect approach might involve choosing a technique that is technically simpler, but offers less access or control for the specific pathology, potentially leading to incomplete resection or increased risk of complications. Another incorrect approach could be to proceed with a technique that carries a higher risk of damage to critical structures, e.g., optic nerve, carotid artery, without a clear justification based on the tumor's extent or the patient's anatomy. Such choices would violate the principle of beneficence and non-maleficence, and could be seen as a failure to adhere to the standards of care expected by the certifying board. Professional decision-making in such cases requires a systematic evaluation. First, a precise diagnosis and staging of the pathology. Second, a detailed assessment of the patient's relevant anatomy, including imaging findings. Third, a thorough understanding of the indications, contraindications, advantages and disadvantages of all viable surgical techniques. And finally, a shared decision-making process with the patient, informed by the surgeon's expertise and the available evidence. Question 20. During the evaluation of a patient who has undergone a total laryngectomy and is seeking voice restoration, the patient expresses a strong preference for a specific type of voice prosthesis, citing anecdotal evidence from a friend. However, the physician's clinical assessment suggests that another voice restoration method might offer a higher likelihood of success and fewer complications for this particular patient's anatomy and lifestyle. What is the most appropriate course of action for the physician? Option A. Engage in a detailed discussion with the patient about all available voice restoration options, including the pros, cons, success rates, and potential complications of each, to facilitate a shared decision-making process that respects the patient's preferences while ensuring clinical appropriateness. Option B. Recommend a less invasive, non-prosthetic voice restoration technique as a compromise, even if it is not the patient's initial preference or the physician's primary recommendation, to avoid potential conflict. Option C. Gently dismiss the patient's preference, explaining that the physician's clinical judgment is paramount and proceeding with the method deemed most suitable by the physician without further discussion of alternatives. Option D. Proceed with the patient's preferred voice prosthesis, assuming their anecdotal evidence is sufficient justification and prioritizing patient satisfaction above all else. Correct answer is A. Engage in a detailed discussion with the patient about all available voice restoration options, including the pros, cons, success rates, and potential complications of each, to facilitate a shared decision-making process that respects the patient's preferences while ensuring clinical appropriateness. Explanation. This scenario presents a professional challenge due to the inherent complexities of laryngectomy and voice restoration, requiring a nuanced approach that balances patient autonomy, clinical expertise, and adherence to established best practices. The patient's expressed preference for a specific voice restoration method, despite potential contraindications or suboptimal outcomes, necessitates careful consideration of their understanding, expectations, and the physician's ethical obligations. The correct approach prioritizes shared decision-making, ensuring the patient is fully informed about the risks, benefits, and alternatives to their preferred method, as well as the potential outcomes of other viable options. This aligns with the ethical principle of patient autonomy and the regulatory framework governing informed consent in medical procedures. Best professional practice dictates a thorough discussion of all available voice restoration techniques, including their respective success rates, potential complications, and the patient's suitability for each. This ensures the patient can make a truly informed choice, and the physician can proceed with a plan that is both clinically sound and ethically defensible, adhering to the standards of care expected by the American Board of Otolaryngology. An incorrect approach would involve dismissing the patient's preference outright without adequate discussion or exploration of their reasoning. This could be seen as paternalistic and a failure to uphold the principles of shared decision-making, potentially violating ethical guidelines that emphasize patient involvement in their care. Another incorrect approach would be to proceed with the patient's preferred method without a comprehensive assessment of its suitability or without fully disclosing potential complications, which could lead to patient dissatisfaction and potential legal or ethical repercussions for failing to meet the standard of care. Furthermore, failing to document the informed consent process thoroughly, including the discussion of alternatives and risks, would be a significant regulatory and ethical failure, leaving the physician vulnerable and undermining patient trust. A professional decision-making process in such situation should involve a structured approach. First, actively listen to and understand the patient's desires and rationale. Second, conduct a comprehensive clinical assessment to determine the feasibility and potential outcomes of all voice restoration options. Third, Engage in a detailed, transparent discussion about the pros and cons of each option, tailored to the patient's understanding. Fourth, collaboratively develop a treatment plan that respects the patient's autonomy while ensuring the best possible clinical outcome. And finally, meticulously document the entire process, including the informed consent discussion.